Question 1. Topic: Vascular imaging and diagnostic testing. A 65-year-old male patient presents with intermittent claudication in both legs, and the physician orders an ankle brachial index (ABE) test. The results show an ABE of 0.65 on the right and 0.62 on the left. Based on these findings, what is the most appropriate interpretation? A. The ABE results suggest mild peripheral artery disease (PAD) and no further testing is needed. B. The ABE results indicate moderate PAD, which is consistent with the patient's symptoms. C. The ABE results are normal, and the symptoms are likely due to another condition. D. The ABE results suggest severe PAD requiring immediate surgical intervention. Answer: B. The ABE results indicate moderate PAD, which is consistent with the patient's symptoms. Explanation: the ankle brachial index (ABE) is a widely used non-invasive test for diagnosing peripheral arterial disease (PAD). The interpretation of ABE values is as follows: 1.0, 1.3, normal 0.91, 0.99, borderline 0.41, 0.90. To moderate E equals 0.40. Severe PAD. In this case, the patient's ABE values 0.65 and 0.62 indicate moderate PAD. Moderate PAD can cause intermittent claudication, symptom characterized by pain or cramping in the legs due to reduced blood flow. Further assessment with vascular imaging such as Doppler ultrasound or CT angiography (ETA) may be needed for treatment planning. Option is incorrect because an ABE of 0.65 and 0.62 is not considered mild. Rather, it falls into the moderate PAD category. Option C is incorrect because an ABE 0.9 is abnormal and indicates PAD. Option D is incorrect because ABE values below 0.40 suggest severe PAD, potentially requiring urgent intervention, but this patient's ABE falls into the moderate range. Relevant guidelines: American Heart Association (AHA) and American College of Cardiology (AC) guidelines recommend ABE testing as first-line diagnostic tool for PAD. Society for Vascular Surgery (SVS) guidelines state that an ABE between 0.41 and 0.90 is indicative of moderate PAD, warranting further risk factor modification and possibly medical intervention. Question 2. Topic: Emergency vascular conditions and critical care. Scenario-based. Mr. Williams, a 55-year-old patient with a history of hypertension and smoking, suddenly experiences severe chest pain radiating to his back. He arrives at the emergency department where his blood pressure is significantly higher in the right arm compared to the left. A bedside ultrasound reveals a dilated ascending aorta with an intimal flap. What is the appropriate next step in managing this patient? A. Start immediate anticoagulation therapy with heparin. B. Administer thrombolytics and monitor for improvement. C. Initiate aggressive blood pressure control and prepare for emergency surgery. D. Perform an endovascular aneurysm repair of R in the emergency room. Answer: C. Initiate aggressive blood pressure control and prepare for emergency surgery. Explanation: this patient presents with symptoms and the imaging findings highly suggestive of acute aortic dissection, likely a Stanford-type dissection due to the involvement of the ascending aorta. The key signs include severe chest pain radiating to the back, hallmark symptom of aortic dissection, blood pressure asymmetry between arms, caused by compromised blood flow due to the dissecting flap, imaging evidence of an intimal flap, confirming aortic dissection. Immediate management includes aggressive blood pressure control, Roman eta blockers such as esmolol or labetalol to reduce stress on the aortic wall, surgical consultation for emergency open repair for type dissections. Option is incorrect because anticoagulation G. Heparin is contraindicated in aortic dissection as it increases bleeding risk. Option B is incorrect because thrombolytics are used for acute coronary syndromes but can be fatal in dissection due to vessel rupture. Option D is incorrect because endovascular aneurysm repair of R is used for abdominal aortic aneurysms, AA, not acute ascending aortic dissection. Relevant guidelines: the 2022 American College of Cardiology, American Heart Association (ACAHA) guidelines recommend urgent surgical repair for Stanford-type dissections. The European Society of Cardiology (ESC) guidelines emphasize immediate blood pressure control, pain management as first-line treatments. Question 3. Topic: Pharmacological and medical management of vascular conditions. A 60-year-old female patient with a history of coronary artery disease, diabetes, and peripheral arterial disease (PAD) is prescribed clopidogrel. What is the primary mechanism of action of this medication in vascular disease management? A. Inhibits platelet aggregation by blocking AMP receptors. B. It directly dissolves existing blood clots in the arteries. C. It prevents blood clot formation by inhibiting thrombin. D. It reduces blood pressure by relaxing vascular smooth muscle. Answer A. Inhibits platelet aggregation by blocking AMP receptors. Explanation. Clopidogrel is an antiplatelet medication that works by irreversibly inhibiting the AMP receptor on platelets, preventing platelet activation and aggregation. This mechanism is crucial in preventing thrombotic events in patients with peripheral arterial disease (PAD), coronary artery disease (CAD), and cerebrovascular disease. Option B is incorrect because clopidogrel does not dissolve existing blood clots, thrombolytic agents like alteplase TPA do that. Option C is incorrect because thrombin inhibitors, e.g. dabigatran, directly prevent the conversion of fibrinogen to fibrin, whereas clopidogrel works by inhibiting platelet activation. Option D is incorrect because clopidogrel does not affect vascular smooth muscle or blood pressure. Medications like calcium channel blockers, e.g. amlodipine, or ACE inhibitors, e.g. lisinopril, target blood pressure regulation. Relevant guidelines: the American College of Cardiology (AC) and American Heart Association (AHA) guidelines recommend clopidogrel as a first-line antiplatelet therapy for patients with PAD to reduce the risk of cardiovascular events. The Society for Vascular Surgery (SVS) guidelines state that dual antiplatelet therapy (DAP) with aspirin. Clopidogrel is indicated after endovascular interventions to prevent thrombosis. Question 4. Topic: Vascular diseases and disorders. Peripheral arterial disease (PAD). Peripheral arterial disease (PAD) is a progressive condition characterized by atherosclerotic plaque buildup in the lower extremities, leading to reduced blood flow. 65-year-old patient with history of smoking and hypertension presents with intermittent claudication, which worsens with exertion and improves with rest. An ankle brachial index (ABE) test is performed, revealing an ABE of 0.6 in the affected limb. The patient asks about treatment options and the potential for progression to critical limb ischemia (CLI). Which of the following statements is correct regarding PAD management? A. Exercise therapy is ineffective in improving symptoms of claudication, and revascularization should be pursued immediately. B. Antiplatelet therapy, lipid-lowering agents, and lifestyle modifications are the primary treatment strategies for PAD before considering surgical intervention. C. An ABE of 0.6 indicates normal arterial supply to the limb and no further intervention is required. D. The primary goal of treatment. PAD is complete reversal of atherosclerosis through high-dose anticoagulation therapy. Answer B. Antiplatelet therapy, lipid-lowering agents, and lifestyle modifications are the primary treatment strategies for PAD before considering surgical intervention. Explanation: PAD management focuses on risk factor modification, including smoking cessation, exercise therapy, and pharmacological interventions, antiplatelet therapy, statins, and antihypertensives. Exercise therapy is the first-line treatment for intermittent claudication as it helps improve walking distance and collateral circulation. An ABE of 0.6 suggests moderate PAD, which may progress to critical limb ischemia ABE 0.4 if left untreated. Surgical intervention, angioplasty, stenting, or bypass is reserved for severe cases, rest pain, ulcers, or gangrene. Anticoagulation is not the primary treatment for PAD. Instead, antiplatelet agents like aspirin or clopidogrel are preferred. Question 5. Topic: Vascular imaging and diagnostic testing. Doppler ultrasound and duplex scanning. 55-year-old female presents with unilateral swelling, pain, and erythema in her left lower limb, raising suspicion for deep vein thrombus (DVT). The physician orders duplex ultrasound to confirm the diagnosis. During the compression ultrasound technique, which of the following findings is the most reliable indicator of DVT? A. Loss of vein compressibility when pressure is applied with the ultrasound probe. B. An increase in venous flow velocity upon manual compression of the limb. C. Triphasic venous waveform pattern on Doppler analysis. D. Reduced arterial pulsatility in the affected limb. Answer A. Loss of vein compressibility when pressure is applied with the ultrasound probe. Explanation: compression ultrasound CUST is the gold standard for diagnosing EV. A normal vein should collapse completely under probe pressure. A lack of compressibility indicates a thrombus. Manual limb compression should cause an increase in flow velocity in a normal venous system, but this does not confirm the presence of DVT, triphasic venous waveforms. Normal findings in arterial Doppler studies, not venous studies. Arterial pulsatility changes are not directly diagnostic of DVT. A DVT primarily affects venous circulation. Question 6. Scenario-based topic. Vascular surgical and endovascular interventions. Carotid artery disease. Mr. Anderson, 72-year-old male with history of hypertension, diabetes, and previous transient ischemic attack. TIR undergoes carotid duplex ultrasound, revealing 75% stenosis in his right internal carotid artery. His physician discusses treatment options, including carotid endarterectomy. C. Carotid artery stenting, CAS. Which of the following statements is true regarding the management of carotid stenosis in this patient? A. Medical therapy alone, antiplatelets and statins is recommended as interventions offer no additional benefit for symptomatic carotid stenosis exceeding 70%. B. Carotid artery stenting, CAS is preferred over carotid endarterectomy. C. For patients over 70 years old due to low perioperative risks. C. Carotid endarterectomy. C. is preferred over carotid artery stenting, CAS in symptomatic patients. High-grade stenosis, 70%, and low surgical risk. D. 75% carotid stenosis is not significant enough to warrant intervention, and aspirin alone is sufficient. Answer. C. Carotid endarterectomy. C. is preferred over carotid artery stenting, CAS in symptomatic patients with high-grade stenosis, 70%, and low surgical risk. Explanation. Symptomatic carotid stenosis of 70.99% is an indication for intervention, either C or CAS. C is generally preferred over CAS in older patients 70 years due to low stroke risk. CAS is reserved for patients who are surgical candidates or have high surgical risk. C. G. Severe cardiac disease. Medical therapy alone is not sufficient for high-grade symptomatic carotid stenosis. Question 7. Topic. Pharmacological and medical management of vascular conditions. Anticoagulation therapy. Which of the following anticoagulants does not require routine laboratory monitoring and has the lowest risk of food-drug interactions? A. Warfarin. B. Unfractionated heparin. C. Rivaroxaban. D. Low molecular weight heparin. Answer. C. Rivaroxaban. Explanation. Direct oral anticoagulants, DOACs, such as rivaroxaban, do not require routine inner monitoring. Unlike warfarin, warfarin requires frequent inner monitoring and is affected by diet, vitamin K intake. Unfractionated heparin requires app monitoring. LAA does not typically require monitoring, but may require anti-Ca levels in certain populations. Renal failure, obesity. Question 8. Topic. Vascular lab and ultrasound principles. Doppler physics in vascular ultrasound. Which of the following adjustments will reduce aliasing artifacts in Doppler imaging? A. Lowering the pulse repetition frequency PRF. B. Increasing the Doppler angle closer to 90 degrees. C. Decreasing the transducer frequency. D. Switching from color Doppler to B-mode imaging. Answer. C. Decreasing the transducer frequency. Explanation. Aliasing occurs when the Doppler shift frequency exceeds the Nyquist limit. Decreasing the transducer frequency reduces aliasing by lowering the detected Doppler shift. Increasing PRF also reduces aliasing, while lowering PRF makes aliasing worse. An angle of 90 degrees leads to no Doppler shift detection, making it useless for vascular studies. Question 9. Topic. Aortic aneurysms and dissections. Pathophysiology and diagnosis. 68-year-old male with history of hypertension, smoking, and hyperlipidemia presents to the emergency department with sudden onset severe back pain and hypotension. Bedside ultrasound reveals 7.2 centimeters infernal abdominal aortic aneurysm A with an intimal flap detected on further CT imaging. Which of the following is most appropriate next step in management? A. Initiate intravenous beta blockers and schedule an elective endovascular aneurysm repair of R. B. Perform immediate open surgical repair due to the high risk of rupture. C. Administer Roman fluids aggressively to raise blood pressure above 104 mmHg to maintain perfusion. D. Discharge the patient with close outpatient follow-up for serial imaging every 6 months. Answer. B. Perform immediate open surgical repair due to the high risk of rupture. Explanation. A rupture is a life-threatening emergency requiring immediate surgical intervention, either open repair or a if stable. Hypotension and back pain suggest rupture or impending rupture. Beta blockers are used in stable aortic dissections, type B, but they're not the primary treatment for a ruptured fluid resuscitation should be conservative. Avoid worsening the rupture. Permissive hypertension is preferred. Question 10. Topic: Peripheral venous disorders. Chronic venous insufficiency (CI) and venous ulcers. 57-year-old woman presents with bilateral lower extremity swelling, skin discoloration, and non-healing ulcers around the medial malleolus. Duplex ultrasound reveals venous reflux in the great saphenous bend (GSB) and incompetent venous valves. Which of the following is the first-line treatment for chronic venous insufficiency (CI)? A. Surgical stripping of the great saphenous vein. B. Long-term anticoagulation with warfarin. C. Graduated compression therapy with lifestyle modifications. D. Immediate intravenous laser therapy. Answer: C. Graduated compression therapy with lifestyle modifications. Explanation: compression stockings 2 3 mHg or higher are the cornerstone of CEI management to reduce swelling and improve venous return. Surgical and intravenous interventions are reserved for cases refractory to conservative therapy. Anticoagulation is not routinely needed unless DVT is present. Question 11. Topic: Vascular physiology. Endothelial function and blood flow regulation. Which of the following is the primary mechanism by which endothelial cells regulate vascular tone? A. Releasing endothelin-1 to induce vasodilation. B. Increasing calcium influx into vascular smooth muscle cells. C. Secreting nitric oxide (NO) to promote vasodilation. D. Stimulating platelet aggregation to maintain blood flow. Answer: C. Secreting nitric oxide (NO) to promote vasodilation. Explanation: nitric oxide (NO) is a key vasodilator produced by endothelial cells, enhancing blood flow by relaxing vascular smooth muscle. Endothelin-1 is a vasoconstrictor, not a vasodilator. A calcium influx leads to vasoconstriction, not relaxation. Question 12. Topic: Arterial blood pressure regulation. Renin-angiotensin-aldosterone system. Which of the following best describes the role of the renin-angiotensin-aldosterone system (ROS) in vascular health? A. ROS activation causes vasodilation and lowers blood pressure. B. Angiotensin stimulates aldosterone secretion, leading to sodium retention and vasoconstriction. C. Renin release is suppressed by low blood pressure. D. Aldosterone decreases sodium reabsorption in the kidneys, reducing blood volume. Answer: B. Angiotensin stimulates aldosterone secretion, leading to sodium retention and vasoconstriction. Explanation: ROS is a major regulator of blood pressure and fluid balance. Renin is released in response to low blood pressure, not high. Angiotensin a potent vasoconstrictor, increasing systemic vascular resistance. Question 13. Scenario-based. Topic: Acute limb ischemia. Diagnosis and management. 62-year-old diabetic patient presents with sudden onset coldness, pain, and pallor in his right leg. He has no palpable pulses in the affected limb. Doppler ultrasound confirms an arterial occlusion. What is the most appropriate initial management? A. Immediate anticoagulation with intravenous heparin. B. Endovascular thrombolysis with alteplase within 24 hours. C. Compression stockings and aspirin. D. Elective surgical bypass after 72 hours. Answer: A. Immediate anticoagulation with intravenous heparin. Explanation: acute limb ischemia is a vascular emergency requiring rapid intervention to prevent limb loss. Roman heparin prevents clot propagation and stabilizes the thrombus. Revascularization, endovascular or surgical, follows after stabilization. Question 14. Topic: Venous thromboembolism (VTE). Risk stratification. Which of the following is major risk factor for deep vein thrombus (DVT? A. High dietary sodium intake. B. Prolonged immobilization or recent surgery. C. Daily aspirin use. D. Low LDL cholesterol levels. Answer: B. Prolonged immobilization or recent surgery. Explanation: DVT risk increases with immobility, surgery, pregnancy, and hypercoagulable conditions. Aspirin does not significantly reduce DVT risk compared to anticoagulants. Question 15. Topic: Vascular surgery. Graft and stent. Complications: patient with aortofemoral bypass grafting presents 2 years later with graft stenosis. What is the most common cause of late graft failure? A. Infection. B. Intimal hyperplasia. C. Thrombocytopenia. D. Hyperlipidemia alone. Answer: B. Intimal hyperplasia. Explanation: intimal hyperplasia, smooth muscle proliferation, is the leading cause of late graft failure. 6 months post-op. Early failure 30 days is usually due to thrombosis or technical errors. Question 16 topic. Vascular imaging. Ankle brachial index ABI and ankle brachial index ABI of 0.3 suggests which condition? A. Mild peripheral artery disease pad. B. Moderate pad with no functional limitation. C. Severe pad with risk of critical limb ischemia. D. Normal circulation. Answer C. Severe pad with risk of critical limb ischemia. Explanation. ABI 0.4 suggests critical limb ischemia requiring urgent evaluation. Question 17. Topic. Stroke prevention in carotid artery disease. A patient with 90% carotid stenosis but no stroke symptoms is best managed with A. Medical therapy, statins, aspirin. B. Carotid endarterectomy. C. No intervention. D. Emergent angioplasty. Answer. B. Carotid endarterectomy. C. Explanation. Asymptomatic high-grade carotid stenosis 80%. Benefits from surgery to prevent future strokes. Question 18. Topic. Carotid artery disease. Stroke prevention and treatment. 72-year-old male with history of hypertension and hyperlipidemia undergoes routine carotid duplex ultrasound which reveals 70% stenosis of the right internal carotid artery, but no history of stroke or transient ischemic attack. TIA. Which of the following is the most appropriate initial management? A. Initiate high-intensity statin therapy and dual antiplatelet therapy, aspirin plus clopidogrel. B. Proceed with carotid endarterectomy. C. Immediately. C. Perform cerebral angiogram to assess the need for stenting. D. Continue monitoring with annual duplex ultrasound unless symptoms develop. Answer. A. Initiate high-intensity statin therapy and dual antiplatelet therapy, aspirin plus clopidogrel. Explanation. Asymptomatic carotid stenosis 50.79% is typically managed with medical therapy unless progression or symptoms occur. Surgical intervention C is considered for stenosis 80% or symptomatic cases. Question 19. Topic. Deep vein thrombosis DVT. Diagnosis and management. 45-year-old woman presents with unilateral leg swelling, warmth, and tenderness along the posterior calf. She recently underwent an abdominal hysterectomy and has been on bed rest for several days. D-dimer test is elevated and a venous duplex ultrasound confirms thrombosis of the popliteal vein. What is the most appropriate next step in management? A. Start direct oral anticoagulation, DOAC immediately. B. Perform thrombectomy due to the risk of embolization. C. Prescribe aspirin and recommend compression stockings. D. Monitor clinically and repeat ultrasound in 1 week. Answer. A. Start direct oral anticoagulation, DOAC immediately. Explanation. Anticoagulation is the primary treatment for DVT to reduce the risk of pulmonary embolism. Thrombectomy is reserved for massive DVT with limb-threatening ischemia. Question 20. Scenario-based. Topic. Acute limb ischemia. Emergency management. 67-year-old man with atrial fibrillation presents with sudden onset severe pain, coldness, and pallor in his left foot. On exam, there is no palpable pulse in the dorsalis pedis artery. Which of the following is the most appropriate initial intervention? A. Stir Roman Hepario immediately and prepare for revascularization. B. Perform emergency limb amputation due to irreversible ischemia. C. Administer thrombolytics via catheter and observe. D. Order CT angiogram and delay treatment until imaging results are available. Answer. A. Star Roman Hepario immediately and prepare for revascularization. Explanation. Acute limb ischemias, a vascular emergency requiring urgent anticoagulation and potential revascularization. Delaying intervention increases the risk of limb loss. Question 21. Topic. Aneurysms. Rupture risk assessment and intervention. 75-year-old male with history of coronary artery disease is diagnosed with 5.8 centimeters in foraminal abdominal aortic aneurysm. Out on routine ultrasound, he is asymptomatic. What is the best next step in management? A. Schedule elective endovascular aneurysm repair of R. B. Prescribe beta blockers and reevaluate in 6 months. C. Proceed with emergency surgical repair. D. Reassess with ultrasound in 1 year. Answer. A. Schedule elective endovascular aneurysm repair of R. Explanation. Our 5.5 centimeters has high risk of rupture and should be repaired electively, even if asymptomatic. Monitoring is appropriate for smaller aneurysms, 5.5 centimeters. Question 22. Topic: Peripheral artery disease PAD. Diagnosis and exercise therapy. 58-year-old woman with diabetes and smoking history reports calf pain when walking that resolves with rest. Ankle brachial index EBA testing reveals 0.65 on the affected leg. What is the first-line treatment? A. Supervised exercise therapy and smoking cessation. B. Immediate percutaneous angioplasty and stenting. C. Surgical bypass of the affected artery. D. Prescribed long-term warfarin therapy. Answer: A. Supervised exercise therapy and smoking cessation. Explanation: exercise therapy improves claudication symptoms and functional capacity. Revascularization is reserved for severe lifestyle-limiting PAD. Question 23. Topic: Varicose veins. Treatment and management. 35-year-old woman presents with painful varicose veins in both legs. She is nurse who stands for long hours. Duplex ultrasound confirms venous reflux in the great saphenous vein. GSV. Which treatment is most appropriate? A. Graduated compression stockings and lifestyle changes. B. Intravenous ablation therapy, laser or radiofrequency. C. Great saphenous vein stripping surgery. D. Long-term anticoagulation with rivaroxaban. Answer: B. Intravenous ablation therapy, laser or radiofrequency. Explanation: minimally invasive intravenous techniques are preferred over surgery for symptomatic varicose veins. Compression stockings help but do not resolve venous reflux. Question 24. Topic: Carotid artery dissection. Diagnosis and treatment. 40-year-old woman with no cardiovascular history presents with sudden onset neck pain and transient vision loss. MRI confirms left carotid artery dissection. What is the most appropriate treatment? A. Start dual antiplatelet therapy, aspirin plus clopidogrel. B. Perform carotid artery stenting immediately. C. Administer omen rhombolysis. D. Surgical carotid endarterectomy. C. Answer: A. Start dual antiplatelet therapy, aspirin plus clopidogrel. Explanation: most carotid dissections are managed with medical therapy unless complications arise. Stenting or surgery is reserved for worsening ischemia. Question 25. Topic: Pulmonary embolism. P. Risk stratification and treatment. 55-year-old man presents with sudden dyspnea, chest pain, and tachycardia. CT angiography confirms large pulmonary embolism. P. But hemodynamics remain stable. EP 125 AMHE. What is the most appropriate next step? A. Administer systemic thrombolysis (TPA). B. Start full-dose anticoagulation with heparin or DOACs. C. Perform immediate surgical embolectomy. D. Place an inferior vena cava IP filter. Answer: B. Start full-dose anticoagulation with heparin or DOACs. Explanation: anticoagulation is the standard treatment for stable P. Thrombolysis is only for massive, unstable P with hypotension. Question 26. Scenario-based. Topic: Raynaud's phenomenon. Diagnosis and management. 32-year-old woman presents with episodic finger color changes, white, blue, red, triggered by cold exposure. She has no signs of tissue damage or systemic disease. What is the most appropriate treatment? A. Calcium channel blockers, e.g. nifedipine. B. Long-term warfarin therapy. C. Surgical sympathectomy. D. Systemic corticosteroids. Answer: A. Calcium channel blockers, e.g. nifedipine. Explanation: calcium channel blockers are first line for Raynaud's phenomenon and avoid triggers like cold and stress. Question 27. Scenario-based. Topic: Thoracic aortic dissection. Diagnosis and emergency management. 60-year-old man with history of hypertension and smoking presents with sudden onset severe chest pain that radiates to his back. His blood pressure is 190/100 mmHg and he has difference of 20 mmHg in systolic pressure between his arms. CT angiogram confirms an acute Stanford type dissection. Which of the following is the most appropriate immediate treatment? A. Romina A. Betalol to lower blood pressure and emergent surgical repair. B. Storomina heparin and monitor in the IQ. C. Endovascular stent placement to close the dissection. D. Administer thrombolytics to prevent clot propagation. Answer: Romina A. Betalol to lower blood pressure and emergent surgical repair. Explanation: Stanford type dissections involving the ascending aorta require immediate surgical repair. Romina blockers, labetalol, esmolol, help control blood pressure and reduce aortic wall stress. Question 28. Topic: Chronic venous insufficiency. Diagnosis and treatment: 55-year-old woman presents with bilateral leg swelling, aching pain, and hyperpigmentation around the ankles. She has history of multiple pregnancies and stands for long hours of work. Venous duplex ultrasound shows valvular incompetence in the great saphenous vein, GSV, but no deep vein thrombus, DVT. What is the first-line treatment? A. Graduated compression stockings and leg elevation. B. Intravenous laser ablation, EVLA. C. Long-term anticoagulation therapy. D. Surgical vein stripping. Answer: A. Graduated compression stockings and leg elevation. Explanation: conservative management. Compression elevation exercise is the first-line treatment. Minimally invasive procedures, EVLA, are considered for persistent symptoms. Question 29, scenario-based. Topic: subclavian steal syndrome. Clinical features and diagnosis: 68-year-old man with history of peripheral artery disease and smoking, reports dizziness and syncope when using his left arm. He also experiences weakness and numbness in his left hand. Blood pressure in the left arm is significantly lower than in the right arm. Which diagnostic test is most appropriate to confirm the diagnosis? A. Doppler ultrasound of the subclavian and vertebral arteries. B. Carotid duplex ultrasound. C. Echocardiogram with bubble study. D. Electromyography M of the left upper limb. Answer: A. Doppler ultrasound of the subclavian and vertebral arteries. Explanation: subclavian steal syndrome occurs due to subclavian artery stenosis, causing retrograde blood flow in the vertebral artery. Ultrasound can detect reversed vertebral artery flow, confirming the diagnosis. Question 30, topic: renal artery stenosis. Diagnosis and treatment: 50-year-old woman with treatment-resistant hypertension is found to have systolic diastolic abdominal brute on physical exam. Her blood pressure remains high despite 3 antihypertensive medications. Duplex ultrasound shows renal artery velocity 300 centimeters with post-stenotic dilation. What is the next best step in management? A. CT or hysterangiography to confirm the diagnosis. B. Start heparin therapy to prevent renal infarction. C. Perform immediate renal artery stenting. D. Prescribe high-dose diuretics and observe. Answer: A. CT or hysterangiography to confirm the diagnosis. Explanation: renal artery stenosis is suspected in patients with refractory hypertension and abdominal brutes. Angiography is the gold standard for confirming significant stenosis before intervention.